Welcome to the Health Pilots podcast, presented by the Center for Care Innovations. This podcast is about strengthening the health and well-being of historically underinvested communities. Every episode offers new ideas and practical advice that you can apply today. This episode is adapted from a recent webinar. Enjoy.
I'm Sophie Bergqvist, and I'm the president of Center for Care Innovations since September. So I joined during the pandemic, and I'm experiencing everything what that means, getting to know a team and partners in a virtual world. And I can't wait to meet many of you in person. I see the light at the end of that tunnel. So Center for Care Innovations has been around for about 20 years. So before we get started, I want to introduce you to who we are as hosts, both CCI, and we do this together with NACHC. So we have been around for 20 years and started off working with safety net providers in California. Over the last 10 years, we have expanded that work to work with partners across the country and also with community-based organizations, knowing that the changes we hope to see and the transformation that the country needs is really about working directly with the communities. So partnership between providers and communities and payers to achieve the change for fair, just, and inclusive opportunities for everyone to be healthy. Can go to the next slide. Our mission, just so you can see what our mission is, that we spark, seed, and spread innovations that strengthen the health and well-being of historically underinvested communities. And we create lasting change in collaboration with our partners in the health ecosystem. Health ecosystem can mean many different things, but one of those partners is the National Association for Community Healthcare Clinics. We work with them on a few programs. We see them as a very important partner, given how they are engaged directly with community health centers across the country. And we see them as a partner for the work to spark, seed, and spread innovation. But over to you, Ron. I would love for you to introduce a little bit about NACHC before we dive into the program for today.
Sure. Thanks, Sophie. And thanks again to everyone for joining us today. I want to also thank our great partners, Sophie and Vinu, and the staff over at the Center for Care Innovations, but also Shelley Spires of the Albany Area Primary Care Association in Georgia, and then Del Garcia of the Migrant Clinicians Network. Just thank you all for partnering with us in this very important work. And again, as Sophie mentioned, I'm Dr. Ron. I'm a family physician, and I have the privilege of serving as the Chief Medical Officer for the National Association of Community Health Centers. NACHC is the national association representing the over 14,000 community health centers sites across the country located in every state, territory, and District of Columbia, serving over 30 million patients annually. And in reflecting on what happened over this past year, I think of three things. First, how the COVID-19 pandemic impacted the lives of our patients, families, and communities we serve, but also the health center staff, their families, and loved ones as well. The second thing was this was a time of unfortunate despair and loss, though it moved us toward a new level of innovation to better meet the needs of our patients and communities. And finally, it brought about a new commitment to health through the lens of health equity, central to the mission of health centers, where we live and work every day. So through this, though this year was really a year of challenge and innovation, we also learned the importance of listening to our patients and our staff and co-designing the solutions with them and not for them. So today's call will further this work by looking at the science of building confidence and trust in COVID vaccines through the excellent work of Sergo Ventures and real stories from health centers on the front lines. So thank you again for this opportunity. And we look forward to working with all of you in finding solutions that add value to our patients and our communities. So thanks again for joining us. Turn it back over to you, Sophie.
Thank you so much, Ron. So that's why we're here today. Most states in the US have now vaccinated 50% of the adult population, and that's a real milestone. And we're starting to have more and more things to celebrate. San Francisco General Hospital had 0 COVID admissions earlier this week. And I think it's important that we celebrate those milestones. But it's also important to remember that we haven't yet climbed the mountain. The threat of COVID-19 is not over. many more people must get vaccinated. And we see a rapid decline in vaccination rate in the country. It is 50% lower, this vaccination rate, in May than it was in April. So it's really tapering off. So how can we reach the people that are facing barriers? And we are here today because many of the providers that we work with are looking for solutions, and they come to us to ask, and we always bring them solutions from other partners that we have. And I'm so grateful that we have 3 fantastic speakers that will guide us and share their lessons today. We're also hoping that will be an interactive session, so share your reflections, ideas, and questions in the chat. The real resources are sitting with you, so put links in the chat if you want to. We will also, after this meeting, make sure that we share resources back to everyone. So the first person I want to introduce is Seema. I met Seema when I lived in India, and I was amazed by how she and her team had the ability to use tools from behavioral science and data science and work with the local communities and together unlock solutions. So Sergo Ventures, that she co-founded, works around the world, and we're really lucky that they have grown their work here in the US. And as an example, CDC has adopted Sergo's vulnerability index in their work to respond to the pandemic. Seema is, as I mentioned, the co-founder and CEO of Sergo Ventures, and she's also an assistant adjunct professor at the Harvard School of Public Health. She worked at the Bill and Melinda Gates Foundation before she started Sergo Ventures. She has a PhD in cellular and molecular biology, which is even a handful for me to say, and a master in neuroscience. And I'm just so grateful to have you here today, Seema.
Thank you, Sophie. Hello, everyone. It's such a pleasure and honor to be here with you today. I'm really excited to learn, actually. So I'm going to get us started right away. Wonderful. As Sophie mentioned, I'm going to talk about our vaccine work. And essentially, the goal here is how can we think about solutions to really drive the remaining gap. Very quickly, as Sophie mentioned, I won't go deeper. We are a nonprofit, Sergo Ventures, and essentially we work in partnership with a range of organizations, public, private. We work with departments of health, community organizations, private organizations, really to unlock solutions to help with a focus on precision, knowing that resources are limited. How can we be super targeted in reaching the communities we want to reach with the solutions that are really going to drive change? So coming to the COVID vaccine uptake, we actually, about a month and a half ago, predicted this plateauing that we're seeing right now. So this green line here were the early projections that were made by the New York Times and others based on the very encouraging daily vaccination rates. And so we were, if we continued on that path, we were expecting to reach about 80% by July. And by asking a simple question in one of our surveys, which is, when do you plan to get the vaccine? We projected this actually plateauing starting in late April, May. And so the orange is a projection. And unfortunately, this projection seems to be holding true. So this is the actual numbers that we are tracking. The about 50% number that Sophie highlighted, as you can all appreciate, that is the one dose. That is the first dose. There's, of course, the second dose that also needs to happen. So the question is, how do we close this gap? How do we ensure, for example, to reach President Biden's goal by July 4th, how do we ensure 70% of adults are vaccinated? So that was our key question, is really how do we look at and understand the barriers to vaccine uptake? And the approach we took is slightly different. So, there have been many surveys out there that are looking at barriers to vaccine and whether people are getting vaccinated. And those are great. And one of the things that we're seeing a lot is the discourses around white versus Black versus Latino communities, Republicans versus Democrats, women versus men. And those are very, very helpful. However, I think one thing to realize that that's not very actionable, right? I think what we really need to understand, what are those underlying reasons, which are very genuine, that people are not getting vaccinated, and how do we target the solutions to the right person? So the approach we took is what we call psychobehavioral segmentation, which is an approach that's widely used in marketing. And that's really about bucketing people to different groups based on the ways they relate to a product or a service. And then the other thing that we're providing is actually granular data. So today I'm going to present you state data, but we are going all the way to the county level, and we are going to be monitoring this over time. So really seeing how these patterns are changing. So the question we're trying to answer is, who is not likely to get the COVID vaccine, why, and therefore how do we respond? There's a lot of work that's gone into it. I'm not going to go into the methodology, but I'm more than happy to answer methodological questions. But through a series of surveys and studies we did since December on various validated nationally representative panels, as well as on the Facebook platform so that we can get very large numbers, we actually identified 5 different types of people living in the United States in the way they relate to the COVID vaccine. So these 5 types are, and this distribution, I just want to say, is from January, and I'll show you how these numbers have changed. But essentially, we have one group of people who we are calling enthusiasts. These are people that are highly likely to get the vaccine. So from a scale of 1 to 10, their likelihood is really high. It's about 9. So these are great. These are probably people like many of you on this call who just could not wait to get the vaccine. And in fact, these are the ones who really got the vaccine so far. Then we have another group which are called the watchful. The watchful are folks that have middle intention to get the vaccine, and they really don't have barriers per se. But what they do want to see is more people around them, friends, family, getting vaccinated so they can feel comfortable, and then they will, jump on the bandwagon. So they want to wait and see. Then these other 3 groups are really the most critical. These are the ones that truly have barriers that we really need to think about how to address. So one group is what we call the cost anxious. The cost anxious are people that have traditionally delayed seeking care, despite the fact that a large proportion of these actually do have health insurance, as per our surveys, about 72%, but they really perceive cost and time barriers in terms of seeking care, and specifically in getting the COVID vaccine. Even though the vaccine is free, they perceive it to cost them something. Another group of folks are what we call the system distrusters. These are people who believe that people of their race are treated unfairly in the healthcare system, by the healthcare system. And then finally, we have this group, what we call our COVID skeptics, which have the lowest likelihood, about 2.3. And these are folks who really don't think that COVID is a concern, and they believe in at least one conspiracy when it comes to COVID. The final thing I will say about these different personas is that all political affiliations and race affiliation and races and ethnicities are actually found in all of these 5 personas or segments. So these are not unique to a particular race or a political affiliation, even though, for example, among skeptics, we find a higher proportion of Republicans and independents, and among system distrusters, we find a slightly higher proportion of communities of color. So how have these how segments of the population shifted, or have they been shifted? And the answer is yes. When we looked at this again in late March, what we found obviously is a large proportion of the adults by then had gotten vaccinated. The share of the enthusiasts went down considerably because many of them got vaccinated. And these middle segments, which we call the persuadable, also shrunk. So the watchful went from 20% to 6%, the cost anxious from 14 to 9%, system distrusters from 9 to 7%. However, the COVID skeptics are the ones that have remained really stable. These are the ones that have not moved, and that makes sense because their likelihood was extremely low. This is a very busy slide, but what we ended up, or we were able to do, is actually look state by state across the United States. So each of these lines represent a single state, and really understand what percentage of the population is of a particular typology. And one of the things we found is, for example, in states like Arkansas, North Dakota, these have the highest proportion of COVID skeptics. And so that's really good to know, because that gives you a sense of what are the barriers in those communities and therefore what needs to be addressed. In states like Mississippi, on the other hand, we found that among their adults, they had a very high proportion of cost-anxious people. And in states like Delaware, actually the highest proportion were watchful. And this just shows you, again, that distribution in another way, highlighting DC, where we see a good chunk of system distrusters, Arkansas, as I mentioned, skeptics, Mississippi, cost anxious, just to show you the variability across the country in comparison to the national picture. This information, or I should say, we wrote and you may have seen it, we wrote a piece about this in the New York Times, which actually allowed people to go in and really understand, get a sense of their states. So that was really interesting to actually see all of the commentary that was coming from the readers in terms of how this related to them. Moving on, the other thing I will say that we also looked at, what are the experience and anticipated barriers in getting or projecting to get the vaccine? And we looked at a number of things from time, website crashing, availability of appointments, difficulty traveling to the vaccination site, etc. And again, here also, so again, this is busy, but I will zoom in. This is showing you the different types of barriers we looked, and each of these dots is a particular state. And we saw, again, a lot of variability across the United States. So the most reported challenges, which is I think is very interesting and important to keep in mind, were actually structural and access barriers. So it was not having time, it was concern over costs, and no available appointments. But although we know this has been addressed recently. So again, for example, in a state like Maryland, 35% of people reported not being able to schedule an appointment. In Arkansas, Minnesota, New York, Wyoming, Louisiana, a good chunk of folks reported not having time. In Nevada and Kansas, more than 10% of folks reported concerns over cost. So what can we do? So once we understand the typologies that people are part of, we can actually think of very targeted solutions. So for example, if we look at the watchful, what is really important for them is, as I mentioned, seeing others getting vaccinated. So it will be important to make this very visible. And also for them to provide a vaccinate late option. For the cost anxious, it is really about bringing the service as close as possible. So using all sorts of models of mobile, vaccinating in grocery stores, in the subway, in community centers, churches, whatever it may be, so that it is very accessible and enabling them to take time off of work. For COVID skeptics, on the other hand, it is really important to listen and acknowledge and not to be confrontational. And then to continue the conversation with your facts. So it is really about listening and acknowledging and providing facts rather than combating their facts. And then the other neat thing about this is you may ask, well, okay, how do I know what typology a person is that I meet or a person in my family? Well, you can ask simple 6 questions, which we were able to develop, which take less than a minute. And with 97% accuracy, the answer to these questions will tell you whether a person is a skeptic, a cost anxious, or watchful, and that will enable you to actually tailor the response. So finally, then how can we use this in a healthcare setting? Well, one way is in the interaction between providers and patients. And one of the things that I think many surveys have highlighted is that people really trust their providers. And so providers have a big role to play in this. And so providers could ask these simple questions if they don't know their patient population well enough to understand what typology that person belongs to, and then put forward a series of messages that we know work for each kind of typology. These could also be integrated into an app. So for example, if you have a way of reaching your community through a mobile app, these questions could be integrated in there, and you could actually understand what a particular type of person is and actually put forward predetermined messages that are targeted for that person. And finally, through our other surveys, and I'm curious to know whether you're seeing this, even in healthcare centers, we see staff that are, that have barriers and that may be still resistant to taking the vaccine. And so this kind of tool can be used in a healthcare setting where, again, it can be used by the setting to better understand their staff and provide them the services and the responses they need. You can actually go on a website, and I can share this link and do this questionnaire yourself and figure out what type of person you are. Or you can do this with a family member or a friend. It's actually really fun. And then it gives you a whole set of prompts depending on the type of persona you are. And that's it for me. So I'm happy to take questions. Thank you very much.
Thank you, Seema. And the first question, which we always get, is what about the slides? There's so many great things in there. And will we be allowed to share the slides with this community?
Absolutely. Happy to.
That's great. Another question is, how have you seen this being used? So you gave a few examples, but in terms of use that has been most impactful from your perspective, you could speak a little bit to that. How was it actually used in practice?
Absolutely. Yes. So different ways. And I will say that we are just in the journey of starting to work with partners. So for example, in Rhode Island Hospital, this has been used in an emergency health department for actually patients coming into the emergency center and the emergency physicians understanding what typology a particular person is, and then thinking about a tailored response. we are partnering with a whole set of health departments that are designing the vaccine uptake responses. And with them, we're working with the county level data to think about how can we have tailored county level responses. So those are the two ways that we are actually using it right now.
That's great. Another question is, what are things that you're learning that you think will be relevant for a post-pandemic world about the personas, but also overall in the work that you've done now on COVID response?
I think overall in the COVID response or on this vaccine in particular?
We can start with this one.
Yeah, with this one, yeah. I think, one of the things we're learning is, we talked a lot about hesitancy. I think in the media, we heard a lot about hesitancy. I mean, one of the important things that we're learning, and it's clear from the data, that actually access issues are still a really big barrier and concern. And so, which is in some ways good news, in my opinion, because those barriers can be solved more easily than, for example, changing a person's belief. So I think access, time, all of those are important barriers. I think the other thing that we're seeing is tremendous variability across the United States, all the way down to state and county level, which really says that the response has to be so locally tailored and so local in terms of where you want to put your resources and how you want to respond. So in my opinion, those are, for me, the big learnings from this vaccine work.
Great. Thank you, Sima. Another question is, does it cost anything to use this tool? And where can they find it? Sophia, your colleague, has put a link to the Precision for COVID. But when it comes to the personas and the tool you just shared, how can people find it? And does it cost anything to use it?
Yeah. So please do. So the tool is available. Please do reach out to us so we can help you think through how to integrate it. It is for free for not-for-profits, but we do charge for for-profit enterprises. So feel free to reach out to us, and we're happy to partner with you and work out a model.
And the vast community here on the call are not-for-profit. So all of you, please reach out to Sophia and Sima. We're going to move on, and I hope, Sima, that you will learn from the coming two presenters that are working on exactly this. We're going to start with Delena Garcia. She is Director of International Projects and Emerging Issues at Migrant Clinicians Network. She has dedicated more than 25 years to the health and wellness needs of migrant and other underserved populations. And we have her here from rural Texas in the car. Thank you for joining us.
Thank you. I apologize for the setting, but I'm on a trip across the border between the U.S. and Mexico, viewing all of the immigrant shelters between San Diego and Harlingen. And so I've now made it to San Benito, Texas. So I have another day and a half. But Sima, I have to say exactly what you're talking about is what we saw in the field and what we keep hearing. And when you talked about underlying reasons, the cost anxious, I think, is truly the case in terms of time and cost originally, not understanding some of the places where you could get it, the fact that they heard so many, then rolled us into those systems distrusters who had that feeling anyway. Certainly when you start looking at immigration and the impact of migration on people's willingness to step up to a governmentally funded and supported process for healthcare. And that what you kept hearing in the news is that even when they were placing COVID centers in communities of color, that 75, 80% of the individuals who were vaccinated there were actually white members of the community who had come into that area to gain quicker access. And so I think that there were a number of individuals who were already fearful, who are already distrustful in the way that you described, Sima, in terms of the systems distrusters, and that the reality of this, as it kept rolling out and systems kept crashing or were difficult to get into, or anytime you showed up, you were asked for some method of identification, hopefully that it would be governmentally sourced, and that is generally not the case, meant that there were a lot of individuals where through word of mouth, and word of mouth is faster than almost anything we've seen because social media is so important, the use of WhatsApp, things that were coming out on Facebook, people were learning right away to, if they didn't distrust it, to distrust it. And that seemed to go up more and more with time. Interestingly, when you started talking about the COVID skeptics, what I've heard in a number of places as I've been interviewing people who were present in that setting. I've been working a great deal in the Mexican consulates because there are 50 in the US. And within the Mexican consulates, there is a project called Ventanillas de Salud. And the Ventanillas are trying to stand up, if not clinics internally to the consulate, then certainly broad connections to local settings where individuals can be vaccinated. And I've been present in a number of these settings and spoken to folks who might not have originally been skeptical, but the amount of negative information that came out in social media, WhatsApp and Facebook and Twitter, Instagram, all sorts of things, was so intense that they then became skeptical of the value of the COVID vaccine. And then we started to see so many more of the messages of it was an effort to implant a chip in my arm so that I could be tracked because people wanted to know about my immigration. And then when they started to have problems with Johnson & Johnson, what immediately emerged was this was an effort to sterilize immigrant women so that they would not be having children at a rate that was then going to mean that non-white populations became the majority over a white population in the next 10 years or so. And so, yes, I agree completely. The underlying persona is so important, and yet it's so mutable because I think that the gentleman that I'm thinking of specifically had already made an appointment, was ready to go and be vaccinated. Between when he made his appointment and the date that the appointment was to come, the amount of negative information that he was bombarded with and was able to take in was enough to make him miss that appointment. And that when I spoke to him some weeks later, made him unwilling to consider it again. And for him to be able to say to me, I am really afraid. I'm very afraid of this. I don't know what it means, but something is going on and it feels like what they're trying to do is hurt me. And so I think that, they might have had an original fear, but then I think that there were a lot of people who, through externally generated fear, then were swayed and dissuaded from taking it on. I do think the issue with Johnson & Johnson was unfortunate because for migrants particularly, the Johnson & Johnson one and done was going to be such a strong solution that even now when you say, but really, the risk of COVID is so far greater than anything that could happen to you as a result because it has been so rare and in such a small percentage of women, it's not sufficient to move many people beyond that. On the other hand, what I will say to you is individuals who are just coming into the country, because my work in the last 10 days has been at the immigration shelters who are receiving people immediately from CBP, from Customs and Border Patrol. And these individuals, by and large, are welcoming the opportunity to be vaccinated. And a majority of the shelters that I visited are utilizing Johnson & Johnson, and they are able to vaccinate, I would say 95% of the immigrants who come in rapid order. Some of them are not there more than 2 or 3 hours, which means that they're going to start traveling right after having been vaccinated. I hope that they are able to take care of themselves and that they don't have really extreme reaction, because some of these folks are in for a 3 and 4 day bus ride to go from, Tucson, Arizona to Bridgeport, Connecticut. But what I do see is enthusiasm, because many of them have been in detention and they do feel like they've been exposed, that there have been no protections for them. And so the first opportunity that they've had to be vaccinated, they're really very excited and very willing. What I have seen, interestingly, at a number of the shelters is that young Latino men seem particularly unwilling to be vaccinated, which is interestingly consistent with some work that we did a few years ago with Latino migrant men. We were able to survey a good quantity of them. Many of them had a misunderstanding about the value of vaccine from a preventive point of view. So I do believe we've not done a good job describing prevention and talking about what it is that you achieve with vaccination. And I do know that if you are from cultures where there's not a real understanding of the benefit of insurance, of doing something today to prevent catastrophe in the future, which is generally the case in much of Mexico and Latin America, that kind of education needs to be thought through more carefully. And that we also heard from these men that they didn't need to be vaccinated because they weren't sick. So they associated an injection with a curative position as opposed to a preventive position. But then they also talked about that they felt like a number of men, not themselves, but a number of men were fearful of needles. And that was keeping them from being vaccinated. And I do see that there is still some of that. And I'm not quite sure, where it's present and what it might come from and what would be our best solution forward, particularly if we have very short time to work with individuals who are being offered a vaccine and are hesitating out of that fear. But I would say that everything that we're seeing on the ground is absolutely consistent with what SEMA's research is reporting, and that all of our work has to be hyper-local directed. We've got to understand where our pockets of individuals who've not accessed, who've not been able to access, or who've been fearful to access vaccination are located, and how we can reach out to them, and what the message for them that will be compelling for their interest is, so that we are really looking at them individually and with a real heart for what it is that might be keeping them from seeking the vaccine care they need. Thank you.
Thank you so much, Del. If you were to point out, I know it needs to be hyper-local, how we respond to this challenge, but if you want to point out a few examples that you have seen most promising in addressing these barriers.
I think what was really wonderful to watch is I was working with one of the ventanillas in South Texas, and the consulate there was very familiar with the areas of her community where individuals might have not fully regularized, which is the word that's used, their immigration status, and that there were large numbers of families there. And she went out of her way to make connections with the schools and the churches and the social service organizations that previously had done elder care. They're just starting to come back online to speak to them about the importance of vaccination, and that as the consul, as someone who represented Mexican nationals in the U.S., she understood the importance and she wanted to offer her own assurance. That was incredible. What I also just saw too is the consul from San Diego was able to work with the maquiladoras in Tijuana, which are essentially U.S. businesses. He was able to do an agreement with the university so that the nurses could do the application, and the county so that he could receive the vaccines, because he was able to approach them and said he understood they had more vaccines than arms. And what they were able to negotiate was a walk across the bridge so that Maquila employees were met by U.S. nurses and vaccinated with county vaccines. And he negotiated 10,000 doses, 9,000 went to Maquila employees, and 1,000 went to immigration personnel from the Mexico side because they had yet not been vaccinated. And these are individuals who move back and forth. They live in San Diego. They work in Tijuana, or, vice versa. They have family members that do both things. And I think that this was a really wonderful solution of seeing where you have American interests on the border. And it just needs to be a collaboration between the medical school, the county, a person like the Mexican consulate, and American businesses.
Thank you so much, Del. We have time for one more question for you, which was, what are you finding to be the most effective and efficient tools to combat misinformation, and particularly when it is given via social media?
I think it is what Sima has said also, which is the more people are seeing family members, neighbors, and friends being vaccinated, that they're stepping forward, that they're taking that action, and that it becomes then more that the person who is unvaccinated remains an outlier in their group. We're working with the Hispanic Construction Workers Association. They were able to call in their memberships of thousands of construction worker foremen to say, bring in your workers, and that it became not obligatory, but as a benefit of membership to the association. And more we started to see construction workers coming in to be vaccinated in large numbers, which was one of the strongest groups that we were working with that were resistant to coming in. They didn't see the value, the time cost, the skepticism, all of it was present. We're seeing it really move differently now.
Thank you. Fantastic example. We see so many inspiring collaborations coming as a response and really finding the strength of other organizations to deliver those messages. So thank you so much, Del. We're going to move on to Shelley Spears. She's the CEO of Albany Area Primary Healthcare, which is one of Georgia's largest community health centers. She has a deep understanding of human resources for health, obviously from her current role, but also previously she was the Human Resource Director at Dooley County Medical Center. Shelley, thank you so much for being here with us today. You are serving a slightly different population from Del that we just heard about. So we'd love to hear, who are you serving? What are the main challenges you are facing? And what are some of the most promising practices that you have been tested and tried out? And maybe tried out things that didn't work. We would love to hear that as well, so people don't try things that are less promising.
Yeah, thank you so much, Sophie. Yes, I'm Shelley Spires. I'm the CEO for Albany Area Primary Healthcare in Albany, Georgia, in case you couldn't tell by the accent. So certainly serving the underserved population, uninsured and underinsured population in the South Georgia area. Just quickly to give you just an idea of the size, we're 27 locations, 47,000 established patients with about 170,000 visits per year. We employ about 371 employees, and I share that data to go on to say that to put how bad it was into perspective, with 371 employees, we had 117 positive within the first 3 months of the outbreak. And so you can do the math and know that that's a huge chunk of my workforce. So it was pretty bad in the area. One of the things that we have continued to emphasize in our community as well with our patient population, of course, is the education component and really understanding the vaccine and what's behind it. So one of the ways we started with that initially with our staff, because there was a sense of hesitancy, if you will, amongst our own healthcare workers. And as I said, we had a huge outbreak within our organization as to why the healthcare employees were not interested in the vaccine. And so we actually are very fortunate to have a variety of providers that are employed with us. And we have one who used to work from NIH. We have one who was a pharmacist before they were an internist, and then we have a general internist. And so we pulled what we call our three wise women together and actually broke it down so that we could understand how vaccines are made, the ingredients in the vaccine, really digging into the statistics and what that looked like. And so we actually made some headway. We went from about 30% up to about 50% just within our own workforce. Today, we've administered over 12,000 vaccines in our organization, and we feel like that's a huge accomplishment considering we're not a big organization. We're a nice size, but we're not huge. One of the things we've realized in some of the interviews and some of the discussions we've had out and about with the community and churches, we're working with them. We've collaborated with the hospital and some others, is that trust is key. And I think Seema alluded to that through some of her data collected with some of the interviews they've conducted. And what I think we have found is our population that is still out there, I think they're more in a watchful, if you will, really wanting to see what happens, what becomes of the individuals who get it, but more so that trusting voice. And that could be the provider, as Seema said. But a lot of times is, even someone in the community that you trust. And so one of the things that we're working on developing is creating community health workers and really establishing that program and taking our mobile units into some geographical areas that we can identify of our own patients who have not received the vaccine, and really just spend some time there once a week until we can, really understand why people are resistant to getting the vaccine. And so that's one of the things that we're excited about implementing and seeing how far it gets us with our patient population. The other things that we have really made sure we tried not to condemn or belittle or, really kind of give a facial expression to the answer, no, I haven't gotten the vaccine, and really just more inquire as to, do you mind me asking why? Do you mind sharing? And for example, yesterday we had our last day of our mass vaccination site. We've moved it back into our clinics. And so I had an opportunity to talk with an individual there receiving her first dose. And if I had to guess, probably African-American female around the age, I'm not good with ages, but about 50. And she said, I was just scared. I was just afraid. And I've had time to kind of see and observe, and I'm ready to do it. I'm ready to get my vaccine. And so it was, interesting to hear that maybe, the time that's been given to individuals to really digest what's going on with the vaccine may be key to us improving that and creating access for those patients who are coming around. One of the things that we did is, of course, we held 2 huge mass vaccination clinics on a Saturday at a gymnasium here, collaborated with the school system. And one Saturday we administered 200. The next Saturday we administered 500 from 8 to 12. And so we really just kind of tried to pick times and days that would bring populations in, I guess, or patients in, and they were near a bus stop. So we tried to make sure transportation was not an issue. We also had opportunities where we would send out patient blasts through text messaging. We would send it out through emails, patient portal. We use social media. We continue to utilize the radio. So we're using all of our outreach avenues to really reach all the patients so that we can make sure they're educated. Our chief medical officer has played a role in making sure the community is aware. And we're continuing to really, try to be creative with our ideas. And so one thing we've done here recently is for our workforce, we were able to give a day off with pay if you were vaccinated. And next month, we are till June the 18th, I believe. If we can get 75% of our workforce vaccinated, we'll get an additional day off. That's free. So just trying to be creative with some incentives for the staff. As far as the patients go, we have actually, we take our patient list. So we have EMR, so we take our patient population out of our universe who have not received the vaccine, and we start working that list. And what we have found is the accessibility is one thing, but patients want to talk to a person. And so when you have things that are online where you go on and register or you go on and sign up, we found was not near as great as the ability to call and get someone at my center. And that's been huge because while they have someone on the phone, they can ask some of those questions when they're on the fence. And so we've certainly tried to make accessibility and the fact that you talk to a real live person easy. So accessibility has been something we've tried to break all barriers.
Thank you so much, and spot on time. First of all, fantastic that you're investing in your own staff and giving them incentives for getting vaccinated, recognizing that they are the ambassador. So creative with giving them the time off. A question around the community health workers that you're working with that are going out to listen. How do you train them to be prepared to answer questions, given the skepticisms they may be facing and different conspiracy theories that they may have to answer to? Was also an earlier comment around that. How do you deal with misinformation, and what position are the community health workers to address that?
Sure. So we actually collaborate with our medical school, Morehouse School of Medicine here in Georgia, and they train the community health workers. And so we go ahead and make sure we have a consistent message, because that's what's going to be key. If I'm a community health worker and you are, either one of us go to that home to visit that patient, we need to have the same message. And so ensuring that we have scripted information where, we don't deviate. We try to stay on task and on track. And if we don't know, write the answers down. So when we go back, we can give the patients the right information. So we try to just make sure it's a consistent message.
That's great. And have you started that work as of yet, or they are in training right now?
They're in training.
Great. And question to you, what are the lessons that you have during this period and the response that you have given for a vaccine outreach that will stay with you, that will inform your work going forward post-pandemic?
Oh, wow. I think that the most important thing is we don't take anything for granted. I think that I was probably so focused on, patient disparities and health disparities and making sure that we move the needle on so many other things that you never stop to think that something could come in and interrupt all of that in a blink of an eye. And we had some challenging times. We lost an employee due to COVID. And I had 2 nursing staff that lost their spouses by taking it home from here and giving it to their spouses. And they unfortunately passed away. And so we're still dealing with a lot of grieving and a lot of those sort of emotions here in our own organization. But, I think, most importantly, we have decided as an organization that where there's a will, there's a way. And we will not let this pandemic keep us from taking care of our patients. And we did. We went outside the box on so many areas to make sure our patients were still seen about.
And hopefully those investments in healing is also things that we can learn and remember for the future. We're going to take a question from the audience. So Matthew McCurdy, he's Director of Programs at Health Design ED at Emory, so in your state. He's also the founder of Black Health, an organization that creates space for critical conversation about racism, health, and new ways forward. He's been very engaged in also vaccine outreach. But Matthew, you can come up on stage and ask your question.
Yeah, thank you, Sophie. So we've been talking a lot about sort of community mobilization and how to get community involved in these vaccine efforts. And so a question that I have is just given that there are different groups, right? We're talking about personas, we're talking about ethnic and racial groups, we're talking about ages, and all of those groups have different structural barriers and different fears. How do you decide on the partnerships that really work and really can be effective for getting to vaccine uptake? What challenges have you had with that, or what successes have you had?
Yeah, so I'll take that one. Okay, good. What we have really focused on is not necessarily which population to put emphasis on, but more so the flexibility from our organization to be able to flex our message to meet the needs of those particular patient populations. So, of course, when we meet with our consortium of Black pastors here that are a group of pastors from a lot of the churches here in South Georgia, we gear our message toward their congregation. So you got a variety of ethnic, you got a variety of ages. And then, of course, when we have an opportunity to go to a high school, we change that message to meet the needs of that particular age population. What we're seeing here in South Georgia is what we're identifying is the age of about 40 to 50-ish that we're really trying to connect with, trying to really understand why they're not wanting the vaccine. So still, again, the message has the same meaning, but it may be the message is a little bit different so that it resonates with that particular population.
And I think that has always been, a difficult piece, because even going into communities now, and we've seen this really come to light with this enormous infusion of money from HRSA and from the CDC. And all of those grants requested that they be coalitions that included a CBO of some variety or another. And what we were hearing from our colleagues in CBOs was, the state doesn't even know we exist. We've never worked with the health department, or the health department has never worked with the health center, or, so what has really become the case is there's needed to be a period of meeting one another. Unfortunately, It's been accelerated by the availability of funds now to do programming. But what it has meant is that if the communities truly understand how to reach in, and they are approached by the state or they're approached by a health center or another group, they are able to say, we know where the arms are and we know how to stand this up. And what we need for you to do is show up with clinicians and vaccines and trust us that we will know how to bring people in. And those conversations have changed a little bit. And it is really my hope now that because this has been a requirement, it will start to be a much easier piece that holds form even after we get past this pandemic. But it is truly turning to the most grassroots of your group and asking with whom is it that they work and with whom have they been successful. And that alliance then can be built out.
Thank you, Del. And Matthew, back to you then quickly for maybe 1 minute. That was great, for Del. And I think that those coalitions, how can we sustain them? Because I think that there's so much more they can achieve for health in our communities. But Matthew, you talked about targeted. So a few words about your approach and what are the tools you use to be targeted and then meet those with the coalitions that you're then addressing the needs of that local community?
Yeah, absolutely. I think here in Atlanta, what we've seen most recently is sort of we've hit a vaccine plateau. And I think people have seen this in other places as well. But there are still people who need to be vaccinated. I think we've talked about that a lot. And those are people who have different barriers and different fears. And so what we've really started to lean into is sort of how can we get better data to better understand who these people are, where they are, and what interventions they need. So with our partners in On Health and also Surgo Ventures, I think Seema, we've worked with you all as well. We're leaning into this COVID Community Needs Index. Really just thinking about, again, at the zip code level, at the census tract level, who really needs to be vaccinated? What are their barriers? And how can we change or modify our intervention to better serve them? So we're trying to do that at the hyperlocal is a term I hear everybody saying now at the hyperlocal level. I love it. And so that's sort of the approach that we're working through right now to customize our interventions based on the need that we see and based on the needs of the community.
I love all of this.
Matthew, I am so old that I remember public health nurses who used to go door to door. Door to door is still going to be one of the only ways we understand fully what's needed in our neighborhoods and in our communities. And so when I see community health workers going out there, for example, we had them working in Puerto Rico before Maria because of Zika. House to house, Maria hit. They could tell you where everybody should be, who was missing, whose house got washed away, and who was still present. So it is that knowing your community deeply that's going to make such a difference.
Thank you so much. So hyperlocal and creating coalitions to allow us to do most justice to that. But thank you for joining us.